Hello and welcome to the Kingdom Strength Podcast. My name is Troy Briscoe, your host. This is a podcast where we get to discuss many different topics ranging from health, fitness, exercise, clinical concepts, patient care, as well as the Christian walk, Bible studies, scripture. So there is something for you. Happy you're here tuning in. Today we have a special guest, Dr. Lydia Clanton. She is a functional neurologist, good friend of mine, and a follower of Jesus Christ. Lydia, we are happy you are on the show today.
Thank you so much, Troy, for having me. I'm happy to be on the show.
Heck yeah. Well, I am blessed you are here. Thank you for spending time today on the podcast. Can you tell the listeners a little bit about yourself?
Yeah, so just like Troy, I graduated from Parker in December of 2025, so just a couple
Mm-hmm.
months ago, with my doctorate in chiropractic as well as my master's in clinical neuroscience. My background in undergrad was exercise science with a minor in psychology, so I've been a little bit on that, like how does the mind work? How does the mind work with the body? That type of walk for a little while. I played college softball, so that's where a lot of my sports performance stuff came in. Played my entire life. And so my focus is really on not only like sports performance side of things, because that's the fun, let's just optimize things, all the way to like rehabbing of strokes, TBIs, concussions, things like that.
Awesome. Great background. It
Thanks.
makes her a monster of a clinician too, I might add, with everything that she has learned and gone through and took time to push herself in within the education that she went through. So again, happy you're here, and let's get into it, shall we? So functional neurology, that is like the big topic of today's podcast. It might be a foreign concept to many of the listeners today. So would you mind taking a moment to explain kind of what that is, Lydia?
Yeah, of course. So if anybody that's come to Neuro Club on campus or has talked to me a little bit, they've probably heard me say this a couple of times, but those that haven't, how I explain it is in traditional medicine, usually whenever you have a concussion, you go to the doctor. They get an x-ray, MRI, whatever they order to make sure you're not having a brain bleed. You didn't have a fracture in your neck, something like that. They want to make sure you're still alive and you're going to be alive for a little while. That's their big thing. Well, if you've ever had a concussion, you know that after one, you do not feel the same for a while, maybe even an extended period of time, depending on how you were able to handle it. So after that, you're like, my body doesn't feel like myself. I just feel off. But the doctor sends you home, tells you you're fine. And to the best of your knowledge, you are. But what they look at is they look at the hard structural damage. So something like a hemorrhage, an actual brain bleed, things like that to make sure you're going to stay alive. Whereas functional neurology really looks at how are you functioning? How is your brain talking to the rest of your body? Is it able to handle pain, brain fogs, things like that? It's the actual true how it functions because you could function at a lower level, even though technically you're healthy by doctor standards.
Mm-hmm. Love that. That is a very good explanation.
Thanks.
How brain functions across the board. I think that is a great summary, and we're going to definitely get into a little bit more clinical experience that Lydia has that she's experienced so far within cases and patient care. So before we do that, though, I kind of want to go a little bit broader scale with just patient care in general and how you have ended where you are per se. Like, why do you look at patient care the way you do, the lens at which you look at through from a functional neurology standpoint, but also I know you kind of have the athletic background weaved in, the like psychological background weaved in. So it's like it shapes into a very unique perspective, and I think it helps your patients that are coming in very well, and it's rather unique. So I kind of want to hear a little bit more about that specifically, kind of how you ended up where you are in terms of the lens that you look at patient care through.
Yeah, so I got into chiropractic at a really young age. Actually, it was because of my travel softball coach. So I decided at 12 I wanted to be a chiropractor. Never changed a thing about that. But as I went into college softball, I just saw so many people in like chronic pain or having ACL tears, labrum tears. The biggest bad thing you can think of in any sport, right? Because you have to have surgery, things like that. But later on in college softball, I did have a couple of friends that suffered from concussions, but not just regular concussions. They were out for 3 months at a time. They couldn't even take their finals. They were in such bad shapes, things like that. So I really just saw where concussions normally you'd think of in 2 weeks, you're better, you can move on with life, and then maybe a month in, you can go back to your sport. But I saw a lot of my friends that actually had like chronic problems after it. So that really got my mind to more focus on the concussion side of things. How can I help? And I didn't really have a route for that yet. And I went to a smaller private Christian school, absolutely loved it, but we didn't have a neuroscience program. So I was already in exercise science, so I went more of the psychology route. And I feel like that gave me a good perspective with it as well, because neurology is your entire body, right? Your brain
Mhm.
runs everything. But also with that, within neurology, there's psychology, because anything you tell your brain, your body's going to believe, because it can barely tell the difference between what's happening to you to real life and your thoughts.
Mhm.
So I feel like neurology, without the part of mental health or the little bit of psychology with it, it's very hard to rehab from it, because if you're telling your brain you're never going to get better, your brain thinks you're never going to get better.
Mhm.
So that's kind of how I went from the sports side to a little bit more concussion to the psychology side. And then I really dove into specifically functional neurology once I got to Parker's campus. Try one, I started going to Neuro Club. And then at try three, I started being the work study up at Parker Performance Institute, where Troy works.
Mhm.
And I learned a lot from my mentors there, Dr. Nikki Kirk, Dr. Brittany Kiros, that's working up there now.
Love them.
And they really helped me through all of that. And with that, I just really dove deep into the Carrick Institute, and that's where I started my diplomate in functional neurology. And then through that, just learning everything from them about the main portions of the system that influence your neurology and your pain, and specifically movement pain. It was just the perfect blend of everything that I wanted to do. Because whenever we're treating someone, we're treating the whole person. Whenever you go to a regular medical doctor, they usually have a specialist in something, a gastroenterologist, a cardiologist. But we're all humans. They all interact. Why are we treating ourselves like one system versus another?
Mhm. Beautiful. I love that, Lydia. Very true. We are treating the whole person and looking at different facets of health and well-being is definitely crucial in our field. And I think as chiropractors, we get a lot of freedom to do that as well, which is such a blessing. And if you're nowhere in one part, it could be having a huge impact on other systems. So all about a thorough history exam, finding low hanging fruit, and moving on and seeing how things change. So I like how you've blended everything together. It's definitely encouraging that there are people in the field like you, Lydia, and I'm excited to get to learn from you constantly, but particularly today on the podcast as well. Yeah, for just a little tidbit, real quick, for the listeners out there, Lydia and I were partners in Neuro
Oh,
Lab.
yeah.
Relied on her heavily. She was a but like we walked in, I think that first day, I saw Lydia in the class and I'm like, "Okay, Lydia, we're partners." It's like I need to
Yeah,
walk with this through walk through this lab with you for sure. So thank you for all your help in that lab. It definitely
of course.
definitely helped. And it was a fun time.
It was. It was.
But awesome. Thank you for sharing all that. Let's pivot real quick and talk a little bit about concussions, if you're cool with that. Cool. Concussion rehab. What does that usually look like? Is there a typical like standardized process you usually go? Is it kind of dependent case by case pretty dramatically, or kind of what's your thought process when someone may roll in with kind of a post concussion situation going on?
So a lot of people, they have this thought of whenever you have a concussion, that you're going to do a scat 5, things like that, like the on field, where are they at, what month is it, things like that. And that a lot of times is not where we come in, because unless you're a DC on the field, you're not going to do the scat 5. You're not going to do the initial, are they alive? Are they unconscious?
Hmm.
So whenever it comes to actually seeing someone in functional neurology at their clinic, usually it goes more like this. They walk in, maybe it's 2 weeks after, maybe it's a month. They're just having these lingering symptoms. Could even be 6 months to a year, but something like finally made them walk into your office.
Hmm.
And once that happens, really, it's just like they teach in school. 80% of what you're going to do in that physical exam and your diagnoses really does come from your history.
Hmm.
Because although a lot of people, they misunderstand concussions, or don't necessarily misunderstand, but they think of concussions as only occurring if you got hit on the head, right? So you could have a concussion from a hit on the head, obviously. That's what most of us know concussions from. But you could also have had a concussion from chemicals. or something like that. So whenever I'm talking about concussions, I try not to think of it as a hit on the head, even though that's what most people think.
Yeah.
But really, what I describe a concussion as is like the metabolic cascade of symptoms and hormonal changes that happens after concussion,
Okay.
especially in the functional neurology world, because like I said, we're not looking for an aneurysm, a hematoma, like a brain bleed, things like that. We're really looking at what symptoms are you coming in with. And the reason concussions are so hard for people, doctors even that specialize in it, is because everyone metabolically is so different. But not only that, the stressors you've had in your life, how you are built, your muscle mass, things like that really play a huge role in how hard concussions hit you. And so it's very difficult to be like, yes, this is the concussion protocol. But how I kind of summarize it is whenever you're going into that initial exam, I have my few things that I'm always checking out neuro-wise, whether it's a concussion, whether I think they have something more serious like an Arnold Chiari, or even like gut problems, because all of those can affect your neuro exam. But I
Mhm.
go in with my basic things, and as I'm doing that exam, I start honing in on, okay, I see a problem here. Let me add this one thing. I see a problem here. Let me add this one thing. So what some of my big ones are always going to be like pupillary light reflex,
Mhm.
because that gives you a real good look into their parasympathetic and sympathetic nervous system balanced eye to eye, right? Same
Mhm.
thing with palate elevation. Another big one I always do is smooth pursuits. So just following the thumb with your eyes. And then another huge one that I always do is rapid alternating movements, a little more for cerebellum, and then
Mhm.
Romberg's a
Little
little more
BDK
for
action.
still cerebellar a little bit, but you can also bring in a little more vestibular system as
Mhm.
well.
Awesome. And, do you commonly see, like, vestibular issues when someone's coming in, with post-concussion symptoms?
Oh, yeah.
Okay.
You will almost always see the biggest one that people see is a convergence issue,
Mhm.
right? So as you're bringing the thumb in, how well do the eyes actually come together and go back out? That's the biggest one you'll see, but you can see things in the pupillary light reflex, the palate. Basically, once you get hit in the head, no matter what your initial symptoms are, your parasympathetic nervous system will be thrown off in some way, which then goes down to all those other systems as well.
Mhm. Yeah. Kind of a cascade effect.
Mhm.
Let's also talk hormones too. I know you mentioned that, and I would love to hear your thoughts on kind of the metabolic cascade that occurs. So yeah, please enlighten the listeners and myself on what happens there.
Yeah, so a lot of people, like I said, whenever they think of a concussion, hit to the head, you're kind of out of it, whatever. Well, when you have that hit to your head, the biggest part of your brain that gets impacted is actually the top part of your brainstem.
Mm,
Because essentially, how a lot of people describe it, and Dr. Sky at my office that I work at, how she describes it is your brainstem is basically the texture of celery, and then your actual brain is the texture of jello. So whenever you have brainstem and brain getting hit, there's the shearing that happens at the top of that brainstem because of the texture difference
mhm.
and because of the spinal column, things like that, right? So whenever you get hit on the head, not only do you have shearing of those axons across that brainstem, which is where a lot of your functional problems come from, is the dying of axons and things like that as it's shearing. But then because of that, your brainstem is where most of your cranial nerves are, right? As well as leading into your hypothalamus and pituitary gland and things like that.
Mhm.
And all of that is where most of your hormones come from, that area right above the brainstem.
Yep.
They're not necessarily coming from it directly, but either actually telling your body when to release it, how much to make, things like that.
Yep.
And so, whenever there's a disconnect of those basically train tracks of things going back and forth, right? Train can no longer run up the brainstem to the area to tell the hormones to release or make more, things like that. And then, even if it did somehow get there, it can't tell the body how to use it.
Mhm.
And so, whenever that track is kind of split or sheared, things like that, that's where a lot of your hormone dysregulation comes from because you're
Gotcha.
basically the part that regulates all that cannot talk or release to the rest of your body.
Cool. Yeah. Yeah, that makes perfect sense. So yeah, I can see where kind of the forces that may be applied with an impact or things like that could change person to person, and
Mhm.
the symptoms could vary based on that. I also have a question about that kind of difference in texture, kind of quote
Mhm.
unquote, or viscosity of different tissue, right? What about the like gray versus white matter example? Is there any sort of shearing or disruption of axons anywhere else in the brain, or is the main focus kind of on the brain stem?
It can happen anywhere. Brainstem just usually gets hit hardest because most of the time when you have a concussion, in the general sense of the term, when you're getting hit, not necessarily chemical, usually that shearing is at the brainstem because of the large difference.
Gotcha.
But gray versus white matter and different parts of the brain can also be impacted. But whenever you are getting hit, let's say you were hit back of the head, right? You're going to come forward, and then what are you going to have? Whiplash.
Hmm.
So then that whiplash, what part of your brain is whiplashing? It's that brainstem. So it can happen anywhere. Brainstem just usually gets hardest, especially depending on if it's like chemical versus a true traumatic injury straight to the head.
Cool. Yeah, that makes sense. And yeah, that's interesting. We have, you used to do work study at PPI, so the concussion cases coming in all the time. So it's been neat to get to be a part of that process and the history and examination when it comes to all that. So I think we covered the examination pretty good. Talk to me about still a concussion train. We'll get off that train here pretty soon, but when it comes to interventions, like what's kind of some common ones? I know it varies depending on what the findings are,
Mhm.
but anything classically like that you like to implement?
Yes. So one of the big things that I feel like I do a lot, even in my little time that I've been out, that I've seen work really well with people, is I treat symptom management and actually the treatment of concussions or whatever I'm treating a little differently.
Hmm.
Because sometimes it really doesn't matter what the problem is that they come with, the diagnoses, but the patients that I see specifically are so light sensitive, sound sensitive, sensitive to anything in the world, basically, that sometimes you can only do one thing with that person before they're absolutely shot metabolically.
Okay.
So, symptom management versus actual treatment are two different things, but I'll explain the differences because I feel like it's very helpful for either people that don't understand or can't quite figure out the difference. So let's say the patient comes in. One of the main ones that I use for concussions would be either like RPSS or vagal nerve stimulation to kind of calm themselves down, right? Or calm their parasympathetic nervous system down. Because what I always like to do is I bring something in to calm the nervous system. That way, as we're trying to treat them, doing a movement they don't like or something like that, we train the body to understand, hey, I can do this movement without feeling sick, things like that.
Gotcha.
Because if you just keep doing something they're bad at, let's say it's eye movements, if you just make them do eye movements, you're going to do one, they're going to immediately have a headache, right? But if you can bring something in there to calm their body down as you're doing it, you might could get 3 or 4 out before they start getting symptomatic.
Hmm.
So one of the big ones that I do a lot with concussion specifically is either no-nos. So basically looking somewhere at the wall or at your thumb and just doing a slight head movement to the right and to the left. Again, it depends person to person because you could also do yes, yeses, depend on your findings. But with that, basically, you're doing a passive eye movement.
Hmm.
So if they've struggled doing their eye movements to the right and left without moving their head right, it's very jumpy, saccadic, then you have them passively do it. You're basically rotating skull around eyes rather
Hmm.
than using eyes and those muscles that are struggling right now. It makes it a
Gotcha.
little easier for them. So that would be the actual treatment, depending on the findings. Obviously, I love no-nos because it's a lot less metabolically demanding. And
Hmm.
since with a concussion, we talked about that metabolic state being so low and that threshold. Another one that I love doing is complex movements, depending on the side of like the DDK with your rapid alternating movements. So a complex movement is just basically taking your arm out in front of you and you want every joint that you can moving. So from wrist to elbow to shoulder and making a big old figure eight with your arm. It's very low on the metabolic threshold, so it's very easy for them to do
Yeah.
metabolically. But someone after a concussion, they're gonna struggle doing it at all.
Mhm.
You'll see that a lot. Those are my 2 big go-tos, especially if they can't do too much at once, which
Okay.
most of them can't. But then what I'll say on that symptom management-wise is, let's say they had trouble doing no-nos, but they had trouble doing it to the right. That was harder for them for some reason, or they got dizzy.
Yeah.
Okay. So if you were trying to manage their symptoms and they were getting a headache from doing it to one side, but were fine the other, to treat their symptoms of getting that headache, you would do RPSS, vagal nerve stimulation, something like that to calm them down. But then you would actually have them do the movement that is easy for them. So if going right's hard, take that section out and have them do just to the left, because that should then activate that part of the brain that's trying to basically come down and calm them down. So
Mhm.
symptom management, you basically do the opposite of what you would do to try to treat them out of that fight or flight stage because you're trying to manage their symptoms. Even though it may not be helping you treat them in the long term, you're treating their symptoms for that moment, if that makes
Sure.
sense.
Yeah. Yeah, that makes perfect sense. And I love those ideas too. And I definitely have seen cases where, for example, complex movements have it's so difficult
Downhill.
for people. So, you need to adapt, you need to shift, that's what probably being a
Mhm.
clinician is about.
Yeah.
But yeah, no, I love your explanation there and the thought process and kind of kinda bridging the gap a little bit, if we will, between kind of the functional neurology, viewing the whole person, and also more of like an MSK approach too. So
Mhm.
something, for the listeners out there, from the content I put out, things I've talked about, it's no surprise I come from more of a active care kind of MSK background when it comes to patient care. And something that, Dr. Kirk, my boss at PPI, has kind of encouraged me to do, which is pretty easy because I'm just a curious guy. I tend to be a bit of a nerd. So kind of bridging that gap between more the funk neuro side and the active care kind of multimodal MSK approach side, finding the similarities. And the beautiful thing is, no matter what technique or system you may be utilizing as a practitioner, if it has solid grounding, then the principles will apply across the
Mhm.
board, right? So that is something I've definitely seen, and I'm definitely practicing, trying to like take a step back, look at a lens from, like you said earlier, the whole person, and seeing where those concepts can apply. So certainly, so with the symptom management and the actual interventions, I definitely have a place in functionality, but also in the kind of the active care side of things too. With I like how you're talking about with layering in the stuff to kind of calm down the system if there's alarm state, and again, that weaves in the psychological approach we were talking about earlier too, with kind of decreasing the perceived threat and maybe giving them, even innately, just their system something that can calm them down. And the way I kind of view it within a MSK approach is desensitizing tissue in order to therefore go in after that's done, whether that's same visit or in subsequent visits, and going in to actually build the capacity of said tissue. But the way you're describing and utilizing is it's weaving it in and at the same time increasing the threshold for their ability to the movements and interventions right then and there. So I think that's quite fascinating and cool to get to play around with and see how people respond to. But yeah, so I don't know, but my mind's been going about just kind of the application of it all, and that's the joy of patient care and being a clinician. There's freedom to do it, and everyone's so unique and different. So it's fascinating to get to see how people respond and kind of like the constraints led approach situation too that we learned about in DMAX class, right? You're changing things, changing the environment, changing the person, changing the task to produce a desired outcome, and seeing if you're moving the needle and in their case and getting the progressions that you want. So it all applies across the board, right? No matter what you're doing, but it all starts with patient-centered care. It all starts with taking a whole person approach, which I'm very encouraged by with hearing about how you go about patient care. So anyway, thank you for sharing all that about concussions. We'll kind of pivot a little bit more into. I kind of want to talk about a little bit the psychological approach.
Mhm.
Whether whatever you want to call it, biopsychosocial, very common in chronic pain scenarios. How does that kind of relate to the functional neurology side of things? I could imagine if someone's coming in with multiple concussions or repetitive injuries, or maybe they've been dealing with like dizziness for a long time or certain movements kind of flare them up. How do you approach that from as a provider? Like, what are you doing with your words, with your dialogue, communication, and how you frame not only the interventions, but also what you're finding in assessments as well?
Yeah, so it's one of the harder things for anyone to deal with. Especially chronic pain, or a lot of the patients that we see are chronic mold exposure, things like that, or more of the true what you would think of as a little almost medical neurology side sometimes.
Hmm.
But a big thing with that is what I've taken from the patients that I've seen so far is that you have to play this game of you need to be able to tell them what's happening without giving them a diagnosis, because I try to avoid diagnosis at all costs, because what is the point of giving them something that they, without them even thinking about it, they feel like they can make it their whole personality, because that's what our brain wants to do. We're in pain and we now know the name to it. That's what all of us want to
You're
do.
like, "Oh, I have that."
Right.
Yeah, you're like, "Oh, that's what identifies me." Yeah.
That's me. Right. And it's not their fault, it's nothing, that's just how life is these days. Get a diagnosis, we wanna hook onto that because we're like, now we have an answer, because that's what our brain wants. So I try to tell them maybe a little bit of the symptoms, what's actually the system causing some of their symptoms. So I try to basically say, "Hey, this symptom that you're having, this your vestibular system is kind of causing you to feel a little off balance whenever you rotate your head because of this, this, and this, right?" And I try to integrate not only the systems that's causing it, but other systems we can use to fix it, because proprioceptive, vestibular, and eye movements, they're all intertwined very closely. So even though one system might not be working for them, we can use the two other systems to help that one system function better. That way they're not as scared. They're like, "Oh my gosh, this isn't working." They actually have the answer to how are you going to fix it without making me sick, because if we just work straight to the vestibular system for a lot of people, it's going to be too much input, because any rotation of their head causes them dizziness. So they're like, "Are you going to rotate me?" Something like that, right? So then if you give them the step by step, well, this feeds into that, and kind of explain that system a little bit of how they work together. And so you're going to go through the two systems that don't cause them problems. I find that helps a lot. But it's also, as you're doing that, just taking a lot of time and care to, if they are feeling those symptoms, symptom manage, as well as, like I said a little bit ago, just basically adding something to calm their system down, because your fight or flight is what's causing the anxiety, the pain, or the excessive pain, things like that. And so if you can bring that down a little as you're having that talk with them, or you're doing the first couple of things, they'll already feel that much better, because you're taking the time to explain it to them, as well as actually they're like, "Oh yeah, my heart rate's gone down, my headache's gotten better," things like that.
Hmm. Yeah, no, I love that. I really enjoyed what you said, too, about staying away from a diagnosis. That's something that I also like to do. There's other like treatment and diagnosis systems or techniques that actually subscribe to such a thought process as well. Like McKinsey, for example, they really
Mhm.
take a step back from the pathoanatomical and see how their interventions are actually changing the symptoms. And again, and function as well. You got pain, function, symptoms, and functioning. If moving the needle on function will kind of move the needle with pain as well. But that's a topic for another day. As far as the pathoanatomical situation, taking a step away because people do like to identify with their quote unquote diagnosis or like imaging findings, for example. But I kind of like to think of it as a functional diagnosis per se, where you're describing what's going on, you're
Mhm.
educating them on what's going on with their body, but you're doing it in a way to where it's not one term or definition that they can potentially be scared of or identify with any potential like fear avoidance they may be going through if this is a chronic pain case, right? So, for example, like when we're talking like MSK, like patient care, it could be like flexion intolerant low back pain, just kind of a general, they're a unique individual. So there's a bunch of details that go into that when it comes to interventions and communication with that, but kind of just giving that functional diagnosis and giving them a game plan and hope for the treatment plan and lay everything out so they can actually have confidence in what they're doing. And having that from the get-go can automatically just kind of decrease that threat and decrease any sort of hesitation they may have with going to even see a provider. So I do like the fact that you mentioned that, and definitely something that I want to implement and continue to implement within my patient interactions. So it's something that I've seen good success with, and people that I've shadowed and mentors that I have, they also subscribe to that thought process. And not to say we forego learning about the mechanisms at play, with what's going on, because that helps us as providers understand, how interventions may affect what they're going through, and exactly knowing what's going on. And it also helps us in our communication too. But, you know, you kind of have to, play with that line between, okay, how much do I educate the patient on everything and how much do I just let that guide me in my process. So anyway, any more thoughts on that before we move on?
No, I mean, I think that's pretty much it. The one thing I will say, I heard someone say this the other day, or it might have been kind of an amalgamation of thoughts of a lot of people. That happens a lot of times
Yeah,
too.
yeah, yeah.
But basically, functional neurology too, or honestly, chronic pain, a lot of it is that even with the absence of disease or disease, whatever, whichever you want to call it doesn't automatically mean that you're healthy.
Hmm.
Because a lot of people, just because they're not in pain or something like that, they didn't have that MRI that said they had something going on. A lot of times they'll be like, okay, I'm perfectly healthy, but then they're like, but why am I fatigued? Why do I have this or that? So just because there's not a pathology, a lot of times people will think they're healthy, which they might be relatively, but then they're still like, okay, then what's the answer to this problem that I'm having?
Yeah, true. No, that's a very good point. Awesome. Well, hey, let's talk about cases or a case. If there's anything that has intrigued you in patient care, any particular case that seemed interesting to you or might be a good learning experience for those listening, is there anything that may come to mind?
So many fun ones. I've had a lot of odd ones, but they're honestly sometimes so complex that I don't even know where to start with them. But one thing that I've seen help a wide range of patients and cases that I've done
Hmm.
is, and I think I'll kind of go into it a little bit more than just like a particular case, but the fact that it's helped so many people with so many different problems.
Okay.
So Dr. Ash, that actually came to the school a couple times, is the reason I've had so much success with this, actually. So all props to him. He made me think about, yeah, he made me think about certain pathways in the brain and how you treat them in such a concise way. And that completely changed things for me.
Mm.
But basically, there is a part of your brainstem called the pontomedullary reticular formation. So PMRF for short,
I can hear Dr. Dishman's voice saying that just in
right?
my ear.
But people on campus have probably been sick of hearing me say it. Y'all are sick of hearing me say it. But that's just how much it's changed so many different people with so many different symptoms that I was just mind blown, even though I've seen a lot, even in my little bit of time just from work study, working with different chiropractors. But I'll give some examples of some of the patients. We had a patient with vestibular issues. Okay. We had a patient that was basically chronic pain, anxiety, also some neurological brainstem stuff as well. So a whole lot of things. And then we also had a patient with PTSD, as well as there was another patient with more of like gut health problems. So like that's a wide variety of things.
Yes.
Quite wide variety, right? And so Dr. Ash, he came and spoke, and basically the little spark notes that he gave to all of us were that your cerebellum runs ipsilaterally on your body, right? So if you're doing rapid alternating movements and you see DDK on one side, that's the side of the cerebellum that's not working as well. But then that left cerebellum actually decussates across to your pontomedullary reticular formation on the other side. which then runs up to that hemisphere. So let's say you had a left cerebellar problem that runs over, you have a right PMRF and a right hemisphere, all downregulated, just not quite working like they should. We all have a little bit of imbalances, but they usually line up really well when someone has a lot of things going on. So then in your exam, you could look at you would see probably a dilated right pupil. You'd see a lower palate on that side. You could see facial tone a little less on that side. And then you see DDK on the left in a perfect world.
Mhm.
So once I started my internship, actually, I went in there and I saw a couple of patients where they were having all of these symptoms. Another thing you can look at is posture. So your pontomedullary reticular formation actually inhibits your flexors above T6 on that same side.
Okay.
So all of those words to mean basically right side of the upper portion of your brain is not working as well as it should, causing your right pec minor to be really tight. So you have more of an internally rotated right shoulder. You have a low right shoulder. And then below the level of T6, it's actually your extensors that are then tight. So then on that same side, your right leg, you'll see maybe external rotation of the foot. You might see a tight glute, things like that.
Mhm.
So posture wise, that's what you can look at more on the MSK side of things, just strictly looking at posture without even
Gotcha.
checking the eyes, things like that.
Mhm.
And then what we did was with a couple of patients that I was seeing that day, we have a ResiMax, which is a neurological vibration tool that a lot of people know about. I think you'll have some up at PPI now.
Yes, we do.
But
Use
we
it
had a
like every
couple of
day.
them. Yep. So we have a couple of them. And what I did without ever actually doing any neurological rehab or MSK rehab on this person, on any of these people, we put a ResiMax on that right pec minor and then underneath the right hamstring. Had them lay down for about 5 minutes, and all of them got up, way less symptoms, and feeling 10 times better. Somebody that had come in not being out of pain in years, her pain that had been there for years, she got up, she like sighed, she was like, I feel relaxed, which was not a normal thing for her to say. And then she also said that her hip pain that she'd had for years was gone.
Lydia, that's crazy.
And so with five completely different symptoms, problems going on, all of those had a complete, almost immediate relaxation, pain going away, things like that. Never touched them neurologically as you'd normally think, right?
Mhm. Mhm.
Or adjusted them or did rehab in any way aside from vibration on two specific muscular points because of how that part of the brain interacts with the rest of it.
So, how does that work exactly with vibration therapy on the muscles that are affected on that ipsilateral side? What's exactly happening there with the PMRF? Is there a lot of research out there about the mechanisms behind that, or how would you explain it to someone that maybe
So,
like what the heck is going on with that? You know what I mean?
right. So, how I explain it, because when I first learned about the PMRF, it was from Carrot's brain based adjusting course, actually.
Okay.
So, the reason that brain based adjusting is different than regular chiropractic adjustments isn't because we're not doing the same thing, we are. But rather than just looking for subluxations or things like that, what you're actually looking for is the neurological signs. So, a tight pec minor. And then you'd adjust that tight pec minor with a quick stretch of the muscle to decrease that tone and then upregulate that part of the brain. But because I was just an intern at this point and these weren't my patients yet, I was like, well, let's try this without us adjusting them. And so my thought process behind it was, well, if we're not quick stretching these, which we do these days, because we've gotten to where we're doing a lot of brain-based adjusting and things like that, but some people can't take that adjustment or they're a little more scared of it. So this is
Hmm.
a easier and less invasive way if there's some of those patients.
Gotcha.
But the quick stretch of the muscle is how it kind of deactivates if we have too much tone there.
Gotcha.
So let's say you did a rib adjustment or a clavicle on me, on my right side, right? Even if you don't get a pop, you can stretch that muscle and that muscle won't be able to tighten as much for a while. And the PMRF, like I said earlier, it inhibits your flexors above T6. So whenever it's not working correctly, it does not turn off those muscles. So those muscles are always overactive because the PMRF is just working at like a lower rate than it should. So
Mhm.
then once we do that quick stretch or that vibration right there, it's sending input to the body to be like, okay, relax, you don't need to be tight, back up to the PMRF and that side of the cortex to then maybe regulate it a little more for the time being until the body can start actually taking in that input like it should.
Okay. Cool. That's fascinating. So when it comes to the, obviously you're talking about the vibration, like the, Resimax or whatever vibration
Hmm.
tool you may have, and adjustment, providing a quick stretch, which with the HVLA thrust. Could you also do, if it's about afferent input, could you also do like manual therapy or even just
Hmm.
like, like a quick stretch in another fashion that isn't with an adjustment?
Yes. So I do a lot of depending on the patients because like I said, if they are in chronic pain, a lot of times you'll notice trigger points and things like that.
Hmm.
But depending on the patient too, you'll start seeing this pattern of, okay, I saw the dilated pupil. And then you're like, let me touch your pec minor or whatever. And then you notice you're like, wow, that literally feels like a rope. Let's work on that. Right. So yeah, I do soft tissue with it a lot. It just basically goes patient by patient, what they like, what they don't like, and what I think would calm their system the best.
Hmm.
Because the thing is, the soft tissue does give that input to the brain. But if we don't pair it with something else, we could do soft tissue till the cows come home on that pec minor. And then the brain is going to tighten it back up because we didn't fully get to the brain.
Hmm.
So once you do that soft tissue or something like that, you need to pair it with something a little stronger
Hmm.
because our body's more used to soft tissue than other things that we encounter day to day that we do at the clinic, if that makes sense.
Yeah. So, for example, I'd love to, I'm going to ask you kind of what you do for that. But for example, when I'm dealing with, hypertonic tissue or trigger points, whatever you want to call it, there's a lot of debate on what trigger points are these days. And maybe we can indulge in that conversation some other time. I'm quite uh, fascinated by it and a bit of a nerd when it comes to that. But, anyways, when it comes to kind of hypertonic tissue, right? Doing that soft tissue work or whatever it may be, adjusting soft tissue. How I'd like to go about it is actually introduce load,
Hmm.
which is, a heavier stimulus, right? And it's actually promoting neuromuscular control. So, say it is a hypertonic tissue, I like good eccentric
Hmm.
loading. And again, this is helping with like range of motion. This is helping with function. This is helping with like motor coordination, right? So, and from an MSK active care perspective, kind of side of things where I come from, introducing that load helps bridge that functional gap and therefore, make strides in the overall function of that system, that individual as time goes on, right? So, I will also not just leave it at manual work. It's definitely good to start with, but then ending with more of that full range of motion, eccentric loading, like stability work, motor control, whatever the issue may be, but providing a higher threshold stimulus to perhaps make a higher impact on like we're talking about the brain, the neuromuscular system to hold whatever we're working on, right? To have bigger bang for our buck and not just waste our time laying on the table, rubbing the boo boo and doing all that jazz, right? So that's kind of where my mind goes. Is
Hmm.
that kind of what you're thinking, or kind of what interventions do you like to use to quote unquote like click save on the document, or really ingrain that in?
Yeah, so I would say I love loading the tissue, especially if I do have more of an athlete or someone like that come in. If
Hmm.
it's more of the neuro, like they are having a chronic problem, or you can tell they're really in pain, something like that, I stay a little more away from that just because they're already so scared of loading it and things that I would do manual, Resimax, something like that. And then a lot of times I'll just take them into the neuro room and either have them do motion guidance for
Okay.
whichever cerebellar was the problem, or a little more of like foam pad work, eye movements, things like that.
Hmm.
So going first into the muscular side of things to start almost priming the brain for it, releasing those muscles, giving them a little bit of that, maybe adjusting them while they're in the neuro room, and then going for motion guidance, eye movement, something like that. So you're going more top down at that point after you've already gone a little more like bottom up.
Audible. Gotcha.
Hmm.
No, I like that. I like that because the load of the tissue is still bottom up. So it would be still be a benefit even if you are loading. In a patient that can do that, it's still wise to go back to the brain specific interventions. So yeah, no, I like that. It's just again, and the world I come from, we weren't doing any of that kind of
Right.
brain-based stuff unless it was a vestibular case, like, for example,
Mhm.
SFMA has a breakout for the vestibular system. So that's the only little window that I had with bridging the gap between the two worlds, the colliding of those two kind of thought processes, right? But yeah, no, there's definitely so much integration there, and the sky is truly the limit, and it really gets me jazzed up and excited about like what we get to do with patients, and how we get to have multiple different systems to have best outcomes for the individual, decreasing their symptoms and increasing their function. And there's so many ways to skin a cat, right? But it's cool to kind of dive into a rabbit hole, get back out of it, see where we want to apply it, continuing to refining ourselves, refining our thought process, and growing for the betterment of our patients. So it's a joy to get to do that, even with you in this conversation today, Lydia. And it's definitely a joy to talk to you. It is encouraging to hear your care and being sharpened and refined by your clinical knowledge and insights. So I definitely value you so much.
Thank you. Same goes to you too.
Yeah, of
I always
course.
enjoy talking to you because you always give me that good perspective of you want to learn from me and things like that. And then you throw something that I might have like known or heard of, but I didn't know enough. And you're willing to do the same for me, kind of teach me that side of things as well.
That's the name of the game. That's what it's
Hmm.
about. And that's why it's a joy to get to talk with Dr. Brittany, right? She
Hmm.
has challenged me and sharpened me so much, and that's what it's about, getting to do that with each other. And again, it's always important to not forget the why of what we're doing. It's easy to be in the trenches of patient care and just kind of get in the habit of doing things right, of how we like to do things. But having that dialogue with other clinicians, and that it is for the patient that we got into this. And no matter how big student loans may be, no matter how busy the day may be, like, nothing's more important than the people that are sitting right in front of us to work with. So anyway, before we wrap up today, Lydia, is there any final parting thoughts you would like to leave for our listeners today?
My main thing is just what I tell a lot of people is pain's not necessarily tissue damage. It can be sometimes, but as we know, when you're looking at an MRI or an X-ray, a lot of people have disc bulges and never have pain till they go in with a symptom and they are like, "Oh, this is causing your pain," when we know it probably wasn't, right? Not that it can't cause pain, but a lot of people have things like that without pain. So it's not necessarily a measure of tissue damage, but it's a measurement of your perceived threat in your body, because it doesn't matter how much you want to do something or how much pain tolerance you do have, your body will only let you go so far, and then it tightens muscles to guard. And so that's the main thing. It's not necessarily tissue damage, but a sheer perceived threat to the world.
Hmm. I like that. Yeah, that reminds me of one of my mentors and people that I've loved to learn from is Annie O'Connor with World of Hurt, and her colleague Melissa. They are phenomenal, but they're big, heavy into the chronic pain world and central sensitization, but just in general, pain mechanisms is kind of what they love to get into. But they treat many different cases, pretty complex neurological cases too, at their clinic up in Chicago. And I've learned a lot from them on that. The concept of the hurt does not equal harm, and vice versa, right? It's so dynamic. People are different. And when you get into early work on the pain science, like Dave Butler, he was kind of a leading, um, thought leadership in that kind of realm too. With hey, just because someone's hurting doesn't mean there's something drastically wrong. That
Mhm.
it is a red flag, kind of a alarm system, quote unquote. I don't use red flag in a classic term when you're, history taking things like that, but kind of an alarm system, right? That there is
Mhm.
perceived threat, on the inverse, if sometimes there is actual tissue damage and you're feeling fine. So yeah, you really at least getting into that stuff really changed the way I looked on pain as well. So definitely important to keep in mind. We're not here to chase pain. We're here to work with individuals and increase their function and their capability to hit their goals that they're currently being limited from. So I love that parting thought. You were awesome, Lydia. Thank you again for being here today. I learned a lot and was sharpened by this conversation, and I sure think that the listeners gleaned a lot as well. So thank you for your time.
Of
Appreciate you a
course.
lot. You are a huge blessing,
You as well,
and
Troy.
looking forward to all the raving reviews that I'll get for having you on the show. But anyway, for you listeners out there, thank you for tuning in. God bless y'all, and we will catch you next time.